Good morning and good afternoon. Welcome to EPAD and EPA webinar series. Today is our 8th series and our topic is on COVID-19 clinical presentation and management strategies with Ethiopian context. Thank you for joining us, whoever is joining us for the first time and who has been following us until today. So before we start, I would briefly introduce both of our association. Ethiopian Pharmacists and Pharmaceutical Scientists Association in Diaspora, known as EPAD, is a nonprofit organization and it was established in Virginia 2018. And EPAD has different members from pharmaceutical professionals and other allied health professionals. EPAD has 4 different working groups: education, regulatory, philanthropy, and investment. And this webinar session is a part of our education series. And as a COVID response, EPAD Philanthropy, along with its members' contribution, provided personal protective equipment to Ethiopia, to the healthcare professionals, such as masks, biohazard bags, thermometers, and also provided some financial assistance to some charities. EPA, also known as Ethiopian Pharmaceutical Association, was founded in 1974, has about 2,000 pharmacists, and also they collaborate with different institutions to promote the role and professional of pharmacy in Ethiopia. And also as a part of the COVID-19 response, EPA closely works with MOH, EPHI, Ethiopian FDA, and with EPAD, and participates in the National Health Professional Councils. As I mentioned before, this is our 8th webinar series, and it's on COVID-19 clinical presentation and strategies with Ethiopian context. And I'll be moderating this session. My name is Rania Almatari. I'm an adjunct faculty at Howard University, also serve as Vice President in EPAD. And with me, Dr. Delbi Hussein will be moderating this session. He's a second-year pharmacy resident and Indiana University Health. You can take over, Delbi, now.
Thank you, Rania, for the introduction, Dr. Rania. Wait for the slides to pop up. All right, good morning, everyone. My name is Delbi Hussein, currently a PGY, transferring to PGY2 Informatics at Indiana Health University. So today's topic will be on clinical presentations of management and strategies with Ethiopia's context. And today we have our panelists, Dr. Iman Ahmed from New York Presbyterian Hospital. She'll be pursuing incoming oncology for PGY2. So Dr. Iman Ahmed is an incoming PGY2 pharmacy practice resident at the New York Presbyterian Hospital. She received her Bachelor's of Science degree from University of Georgia and a Doctor of Pharmacy degree from Howard University College of Pharmacy. She recently completed her postgraduate year 1 training at the New York Presbyterian Hospital and will stay on to complete her PGY2 training to specialize in hematology oncology. Iman's professional interest includes research and advancement of oral chemotherapeutic agents. I'll go ahead and also introduce the rest of the panelists for the sake of time. Our second speaker will be for today's webinar will be Dr. Paulus Ketema. He is an incoming PGY2 pharmacy practice resident at Boston Medical Center. He received his Bachelor's of Arts degree in biology from the University of Maryland, Baltimore County, and a Doctor of Pharmacy degree from Howard University College of Pharmacy. He recently completed his postgraduate year 1 training at the Washington, D.C. VA Medical Center, and now he will be pursuing his second-year training to specialize in infectious disease at the Boston Medical Center, and his professional interest includes ID, internal medicine, and academia. Our last presenter for today's webinar will be Dr. Mikia Stafari. He is a medical doctor currently working at the Ministry of Health as Deputy Director and as a National Coordinator for Surgical Service Improvement for the past 2 years. He has been supporting development and implementation of various national programs such as surgery, quality improvement, projects and is also involved in a different research program, evaluations activities. He is passionate about the science and practice of improvement. Currently, Dr. Mikias serves as the chief lead for the National COVID-19 Clinical Case Management at the Emergency Operations Center, Ethiopian Public Health Institute. With that said, today's topic will be very interesting with regards to the different perspectives of the US, how we handle and treat COVID patients here versus as well as what we are doing in Ethiopia. So today's topic discussions will be with the first topic presented by Dr. Iman Ahmed will be multi-system inflammatory syndrome in children, clinical presentation and management in pediatric patients. Then the second speaker will talk about the supportive care with focus of anticoagulation and steroid therapy. Then our last presenter will talk about the current management of COVID-19 in Ethiopia. Without further ado, I would like to introduce our first speaker, Dr. Iman Ahmed.
Thank you, Delby. I will now share my screen. All right, so thank you for the introduction, Rania and Delby. So today I'll be talking about multi-system inflammatory syndrome in children based off my experience and just a couple of case reports and literature, even though it's minimal. So in the few minutes that I have, the objective will be to discuss the clinical presentation of multi-system inflammatory syndrome in children, known as MISC, and the difference between that and Kawasaki disease, and then additionally review the medication management strategies in pediatric patients with MISC. So in terms of clinical presentation with MISC, it's actually very interesting. It varies. Some of the most common ones are, of course, fever, hypotension, tachycardia, abdominal pain, and altered mental status. And then the pediatric patients tend to have these mucocutaneous rashes that can be anywhere on the body. I think the biggest thing before I even start talking about the medical management and the presentation of MISC is distinguishing that between Kawasaki disease, which tends to be a hot topic currently. So Kawasaki disease is a medium small vesseled vasculitis from an unknown origin, and it's mostly seen historically in children that are less than 5 years of age. And the main complication that is seen when patients present with Kawasaki-like syndrome or disease is that they tend to have these cardiac abnormalities that are either coronary dilation or aneurysms. And if Kawasaki disease is not treated early on, these patients have a 40% chance of developing these coronary dilation or aneurysms. Interestingly, Kawasaki disease has not been associated with any specific microorganisms or any specific targets or genetic factors that predispose patients to have Kawasaki disease. Its underlying pathogenesis is not completely understood. On the flip side, multi-system inflammatory syndrome in children, there are quite a few definitions that have been proposed. I'm presenting the World Health Organization definition, but the CDC has a different definition that's slightly different. And then if you look at some of the organizations and committees in Europe, they also define MISC a little differently. So according to World Health Organization, they define it as children with a fever for at least 3 days and any of two of the following. So either a rash or a non-purulent conjunctivitis or mucocutaneous inflammation signs, hypotension or shock, myocardial dysfunction, evidence of any coagulopathy, and then acute GI problems. In addition to this, they have to have some exposure to COVID-19 or any previous infection. Additionally, they have to have elevated inflammatory markers, as we'll discuss. And then they also it has to be ruled out that they don't have any other causes to lead to this multi-system inflammatory-like syndrome. And I just want to point out, there was a really good paper that was published from, I think it was from Paris, actually, in April. And they kind of highlight the pediatric patients that presented in this time period. How does their presentation compare to patients with Kawasaki disease? And it's really important to be able to distinguish that, so that way the treatment is slightly different, as we'll discuss. And so what they found was, although many of the patients present with skin rash, the few differences is that when patients present with MISC, they have lower platelet counts than patients with Kawasaki disease. They have more so lymphopenia, so they have lower lymphocytes. And then the biggest thing is the cardiac picture or the abnormalities seen in patients with MISC, which is mostly just myocarditis and pericarditis. And then the echo will be abnormally different. In terms of the laboratory abnormalities, there hasn't been a consensus on which abnormalities or which lab abnormalities to look at or distinguish it of MIS-C. So there are quite a few, but the most important that I want to highlight, especially when you're in practice and you're and you know, as a provider, you're considering MIS-C, it's the elevated inflammatory markers, so your CRP, your procalcitonin, and then most importantly, your myocardial enzymes. Troponin and BMP are really important to test for, because patients tend to have extremely high levels of their myocardial enzymes at presentation, which leans you towards more so MIS-C than Kawasaki disease. And then additionally, it's not exactly correlated, but patients tend to have extremely high levels of ferritin, creatinine, low albumin, lymphopenia, as we discussed, and then they have a differentiation of cytokines. So with cytokines, they tend to have extremely high levels of IL, either 6 or 1. They have moderately high levels of TNF factors. So it's a variety of different laboratory maladies, but the most important are going to be your inflammatory markers and your myocardial enzymes. I want to just briefly discuss cytokine release, because that's also what we tend to see. And although the pathogenesis of this multi-system inflammatory syndrome is not completely understood, what we do know is that these patients tend to have this extreme release of cytokines, and that's essentially from a trigger. Most importantly, maybe I did not say this before, but these patients don't have an acute COVID infection. So when these pediatric patients present to the ED, it's not that you do a nasal swab and they are positive for COVID or have really high viral loads. It's actually sometimes undetected or low viral loads in these patients. But what they do find is they have antibodies that show that they have been exposed at some prior time. And this exposure could be as low as 2 weeks or 4 weeks. What's reported in Europe and Paris is that after that highest peak in April, the pediatric population that was being infected with this multi-system inflammatory syndrome or presenting with this was about a week later. So they correlated it to the fact that it was a peak and maybe these patients had some type of exposure to cause a cytokine release. And so with the cytokine release, this is what causes the multitude of clinical presentation and variety and symptoms, and then even in degrees. Some patients will present with a higher severity than others, but there's no distinguishing factor that can predispose a pediatric patient to present with more of acute disease. And then just in terms of care, ICU care is seen very often in the pediatric populations. And it's not that they require respiratory support, it's actually the opposite. I know in the adults, we are understanding them more and they require respiratory or ventilator support, but in our pediatric population, it's actually the opposite, very low incidence of requiring ventilator support or respiratory support. So in terms of the diagnostic workup, it's really important to obtain some type of SARS testing. That could be, or SARS-CoV-2 specifically testing, whether that's serology or nasal swabs, to see if you can identify some type of exposure to the patient. And then your multitude of laboratory tests and diagnostic workup. There's nothing specific that is highly recommended, except especially looking for the cardiac abnormalities, as we discussed, inflammatory markers, imaging such as echo. And then additionally, since patients present with this, really non-specific clinical presentation, if patients present with a specific organ dysfunction or end organ disease, then following up with any consult service that is either neurology or GI, whatever they present with. So in terms of medication management, although I would love to say that there has been a great new novel therapeutic option for our pediatric patients presenting with MIS-C, there really isn't. But what's really interesting is that the mainstay of treatment is steroids, so it's methylpred, but the dose is actually very interesting. It's extremely high. It's 2 to 30 mg per kg per day. Those patients who have really high severe disease, will go ahead and bolus them, or not bolus them, give them a really high doses of steroids from 20 to 30 mg per kg per day. And when you think of that in relation to patients who present with septic shock or requiring pulse dose steroids, doesn't even remotely cross to be as high as this 20 to 30 mg per kg per day in patients. And so for multiple reasons of why methylpred seems to work, as you can imagine, the mechanism of really blunting this cytokine release and this inflammatory cascade is really the reason why we give steroids first as soon as we can, even when patients are in the ED. And it works pretty well in the pediatric populations. I know there's controversies in the adult side, but in the peds, it tends to work really well. And so we give them high dose steroids. And then what's interesting is that we taper them over a longer period of time, so at least 2 to 3 weeks. And that's mostly because, of course, of the adverse events that you tend to see with steroids, your hypertension risk, your endocrine dysfunction, electrolyte abnormalities. But the thing is that if you stop the steroids too early or you don't taper them and you're giving them such high doses, it could potentially have a rebound effect. In addition, the mainstay is steroids and methylpred, but there has been some usage of IVIG, which is honestly just a blood product that provides the patients with antibodies to fight a variety of infections, whether that's viral, bacterial, etc. And there hasn't been a consensus on when to use it. If a patient presents with this MIS-C and you're suspecting any type of Kawasaki disease, whether that's asymptomatic or not, or confirmed, then IVIG is more, should probably be more on your radar to use than not using it at all. In terms of the adverse events, it's mostly just hypersensitivity reactions and administration, which is really key to giving IVIG. You have to pre-medicate with acetaminophen and diphenhydramine prior to the infusion, and then you would need any type of hypersensitivity reaction that may occur, which is epinephrine or hydrocortisone. In terms of other therapies, there are a plethora of other therapies that are being trialed and being looked at retrospectively. A few are anakinra, as many of you have probably heard. Tocilizumab has quite a few studies in the peds population that's being, that you could probably look up. And then you have a bunch of other immunomodulators, your infliximab or your JAK inhibitors. But I couldn't really find anything concrete in terms of these agents in the pediatric population, especially when they're presenting with MIS-C. But just keep this in mind that maybe in the future, whether that's in the next couple of weeks or a couple of months, you might see this as an opportunity. But regardless, the mainstay of treatment is really steroids, and that probably is a controversy when you think about it in the adult side. Additionally, what's interesting is that when these patients present with MIS-C and we give them these high dose steroids, their turnaround time that I've seen honestly is pretty quick, within a few days. 2 to 3 days, they tend to do really well, and they could be either stepped down from the ICU or even discharged home. I think what the key thing to note is that there hasn't been a consensus on post-discharge medication management. So while in their hospital, additional to the steroids and potentially IVIG, we do give them prophylaxis, stress ulcer prophylaxis with either pantoprazole or famotidine. We give them proper anticoagulation. We also start broad-spectrum antibiotics for this potential of this superimposed infections that could potentially play a part. But what's interesting is that we've seen potentially when patients get discharged, they definitely need a cardiac or cardiology follow-up because of the high risk of cardiac dysfunction post-exposure or post-MIS-C. And so we'll tend to see that we send pediatric patients home with low-dose aspirin to prevent this cardiac abnormalities in the future. How long you keep the patients on these low-dose aspirin is not completely understood. I think as we learn more about it, we might have more information. But I have seen that these pediatric patients will go home on low-dose aspirin to prevent this. And I kind of talked about it, but the recovery time in pediatric patients compared to adults is pretty quick. Within a few days, it can present with severe inflammatory markers and ferritin and cardiac markers or cardiac enzymes. And then within the next 2 days, they tend to do pretty well and recover pretty quickly. And they are alive at discharge. Most patients are alive at discharge. And that is multisystem inflammatory syndrome in children in a nutshell. I can, I'm happy to take any questions or kind of talk about a few things that you all have, whether that's in the chat or through the panelists. I think there's a couple questions. Let me see if I can pull it up.
So we'll be allowing the attendees to ask a couple questions, max 3 questions per speaker. So the first question was from Wabebi. So the question was, recently, dexamethasone has been discovered in the UK to be effective for a severe case, cytokine storm. You mentioned about methylprednisone. How do they differ?
Sorry, I was moving my screen. So in terms of dexamethasone?
Yeah, so how do the dexamethasone that's been discovered to be effective for the severe cases differ from methylprednisolone? It's also in the chat box.
So that's a good question. I know that there was a recent study that has been proposed with dexamethasone in the adult population, but we have not used it in peds. Methylpred is what we go to, and that's mostly because of the blend of the glucocorticoids that you can get more so with methylpred. And dexamethasone is a potent steroid, but we have used methylpred for the balance of the glucocorticoid and the mineralocorticoid mix or better response with methylpred, whereas with dexamethasone, you only have this glucocorticoid response or glucocorticoid effect, essentially.
Two more questions and then we end it. The second question is, can you discuss the risk of Rye syndrome?
I haven't seen that, so I can't comment on the risk of Rye syndrome. I am not too sure if I haven't seen it at all in my couple months with COVID in the pediatric population. So I'm not sure how the incidence of that risk with that is.
Okay. And the last question would be, is inflammatory cytokines released for all patients? I believe they're trying to ask as a biomarker or in terms of COVID patients.
No, not as a biomarker at all. Honestly, just as a laboratory abnormality that you see when patients present with a fever of unknown origin, extreme abdominal pain, and GI upset, nausea, vomiting in these patients. The PEDS patients tend to have headache, etc. Then you do this, extensive diagnostic workup, and then that's when you look for these inflammatory markers and any of these cytokine factors that you may potentially suspect in this patient. So it's not a biomarker necessarily, it's really just a diagnostic measure. And it hasn't even been completely correlated to MIS-C. It's just that when you look at the few studies that have been published, they tend to have higher levels of your interleukins and some of your TNF factors. So it's just a measure currently kind of for diagnosis, but not at all for biomarker or even prognosis at all.
Thank you. So now we'll move on to the next lecture, presented by Dr. Paulos Katema.
Can you all hear me okay? I think you guys can hear me. Thank you so much. So today my focus is going to be on supportive management of COVID. And specifically, I want to focus on a couple of different topics. The first topic that I want to focus on is anticoagulation management, followed by steroid therapy, and then what role do pharmacists play a role in these patient populations. So looking at COVID-19 associated coagulopathy, as with other infections such as SARS and Middle Eastern respiratory syndrome, COVID-19 has the potential to have a severe illness, including systemic inflammatory response syndrome, acute respiratory syndrome, and multi-organ involvement, as well as shock. And we know all of those are precursors for patients to become prothrombotic or to give rise to thrombosis. And looking at hypercoagulability with a bird's eye view, we can see that we can look at it from the Virchow's triad, right? So if a patient has either one of these being the endothelial injury, the hypercoagulable state, as well as stasis, all of those would give rise to thrombosis, right? So particularly in COVID-19 patients and those with severe disease, they may actually develop hypercoagulable state, and therefore we need to introduce some sort of pharmacological intervention. Not only is the infection is thought to put patients at a hypercoagulable state, but some of the management, some of the drugs that we use could actually interact with some of the anticoagulation and anticoagulant agents that we use currently. So looking at that, there has not been a very well understood mechanistic as to how COVID-19 actually puts patient at risk for hypercoagulation. Actually, COVID-19 puts patient at a hypercoagulable state. But what is proposed is that, and it's seen with other infections as well, when we have these infections, the infections sort of introduce these inflammatory biomarkers, right? Once these inflammatory biomarkers are introduced, then endothelial and homeostatic activation ensues, which increases those clotting factors and increased tissue factors. The fact that we have these homeostatic activation, and again, sort of induces the inflammatory response to severe infection. And this is really marked by the lymphopenia as well as the thrombocytopenia that's seen in a lot of COVID patients. It's this presentation, or it's this activation within the cascade that actually puts patients at an increased thrombotic state, therefore giving rise to possible VTE, myocardial infarction, and severe homeostatic derangement that actually puts patient at risk for disseminated intravascular coagulation. And we know that there's going to be a number of labs that are ordered from the hematology side of it. We know that we're going to get our basic CBC, PT, INR, APTT. But what they've seen specifically in COVID patients is that although there are other abnormalities, the two most consistent abnormalities within the coagulation are this mild thrombocytopenia, as well as this elevated D-dimer levels. There's some evidence that show that some patients may have high fibrinogen levels. However, again, the two most consistent laboratory values that are going to be abnormal are going to be the thrombocytopenia as well as the elevated D-dimers. And this elevated D-dimers is pretty interesting. The European Society actually uses these D-dimers to sort of stratify patients as to whether they get one treatment over the other. But we know from a number of retrospective studies now that the elevated D-dimers actually is a prognostic factor in terms of mortality. So the higher the D-dimer level, the higher the mortality rate, or the higher the lower the prognosis, right? And there was a couple of studies that looked at the coagulopathy, the association, and the poor prognosis. So Tang and colleague, they looked at what they found within their studies was 75% of patients who died actually met the criteria for DIC, while only 0.6 survivors met the criteria of DIC. And it's sort of the same presentation with the Chen and colleague study, and then as well as the Wang and colleague, and that the higher the D-dimer, the worse the prognosis. And patients who have severely ill presentation tend to have those D-dimers elevation and tend to be in those ICU settings. So the question is, we know that these coagulopathy or these disorders are going to be it's going to put patients at a really poor prognosis, and mortality ensues next. So what do we do about it? So from the recommendation from the various guidelines and from the various governing bodies is that we should introduce some sort of pharmacological agent, right? So the recommendation is hospitalized patients with newly or confirmed presumptive COVID-19 infection, number one, should have those tests performed, whether it be D-dimer, fibrinogen, all those tests should be ordered. We know that the elevation in D-dimer, or the abnormalities within the coagulopathy, it's going to happen anywhere between 7 to 10 days of hospital admission, because that's when patients go from having just the infection to presenting with severe illnesses, right? And lastly, the progression of coagulation also changes not only from the COVID-19 infection itself, but other factors such as prolonged hospitalization, mechanical ventilation, superinfection that may be there, and other typical ICU settings. So who gets pharmacological agents? Well, let's stratify the patients into different groups. We have patients who have COVID-19 infection that may be asymptomatic, or that may be mild, that may present with mild symptoms, but not hospitalized. We have patients who are hospitalized, and then we have also patients that got admitted to the ICU setting, or that got into the hospital, maybe perhaps received those pharmacological agents and then discharged. So when we think about giving pharmacological agents, we need to stratify these patients into these groups. We also need to stratify these patients into the various risk assessment. So the recommendation is that for non-hospitalized patients, we should not be ordering any laboratory test, as well as we should not be starting any pharmacological or chemoprophylaxis agents. And this is largely because there's a lack of data demonstrating that they're actually beneficial in those patients that are non-hospitalized. However, in the hospitalized patients, regardless, in those that have newly confirmed or presumptive COVID-19 infection, number one, we should perform those coagulation tests, and number two, we should start thinking about giving those pharmacological agents, because we know at some point within their hospital stay there's going to be severe inflammation, which puts patients at risk, at prothrombotic risk. So we sort of need to get ahead of it by giving some sort of pharmacological agent. Now, the biggest question or the biggest debate is, do we do a full therapeutic dose or do we do a prophylactic dose? Or do we do something in between, right? If we give too much, we put patients at risk for bleeding. If we give too little, we put the patient at risk for clotting. So there's got to be a balance. And looking at the recommendations from the various governing bodies, it's sort of the same. They sort of have the same guidance. Number one, we should stratify patients into different groups. They recommend using VTE, or venous thromboembolism risk assessment. I think the most common one is the IMPROVE model. This is the International Medical Prevention Registry on venous thromboembolism. We should risk stratify those patients, but overall, all of them pretty much says that you should use prophylactic dose, just because there's not a lot of data in using therapeutic dose in these patient populations. And the recommendation, again, across the board from the International Society of Thrombosis and Hemostasis, the American Society of Hematology, as well as the WHO, as well as the American Cardiology Association, is pretty much to say that you should use those prophylactic doses, your low-weight molecular heparins and unfractionated heparins. So again, the choice of therapy in patients who are hospitalized and not in DIC is prophylactic doses. If for any reason there is a contraindication for patients to receive those prophylactic doses, the low molecular weight heparins or the unfractionated heparins, then we can consider intermittent pneumatic compressions. Again, there are insufficient data to consider routine therapeutic or intermediate doses for COVID-19 patients, but with practice, and I know I've seen it at my institution, some practitioners, they use the 0.5 milligram per kilogram dose, but however, again, those are not really understood and those are not really supported by randomized clinical trials. In patients with moderate to severe infection and in DIC, but if they don't have any overt bleeding, then again, the recommendation is to continue to use those prophylactic anticoagulation. Again, there's insufficient data to sort of recommend the therapeutic or intermediate dose of parenteral anticoagulation. And lastly, this is the third group. Well, the debate is patients will still be hypercoagulable even after COVID infection, after they may have cleared the COVID infection. So is there enough data to support that we should be sending patients on a Lovenox at home for a certain number of days? And there's not really that much data to support that as well. So the recommendation, again, from these governing bodies is that we should not be putting patients, we should not prescribe anticoagulants, either therapeutic or prophylactic, once they've been discharged from the hospital. However, in certain patient populations, it may be reasonable to start those prophylactic anticoagulation, given that they may have low bleed risk, or it could be patients who may have been admitted to the ICU, intubated, sedated, or possibly paralyzed for multiple days. So because we know that the risk of VTE still lingers even after COVID treatments. But largely the recommendation is that once they're discharged, just leave them alone and not start any anticoagulation. So that's in summary the first part of the presentation. So the second part of the presentation is the corticosteroid therapy. I know with the recovery trial that this is going to become a hot topic. So I just wanted to highlight a few things about steroid therapy and its role in the management of COVID-19. Right. So there's been a lot of research with the use of steroids and the proposed benefits in some viral infection as well as ARDS. So the steroids are sort of a twofold, right? So they suppress the immune system and also inhibit some of the inflammatory biomarkers. So prior to the recovery trial, we've known a couple of things about corticosteroids. Number one, steroids have been associated with prolonged viral shedding in MERS and SARS patients, although those studies had a very small patient population. Number two, in influenza, actually, steroids have been associated with somewhat increased mortality. And number three, that as Iman presented in her earlier slides, steroids are associated with a number of adverse effects, including hyperglycemia, pneumonia, psychosis, which sort of blends everything within the COVID patients and making the treatment more harder. So if we look at the COVID infection in a very simplistic manner, looking at it from stage 1 to stage 3, stage 1 being the at admission or at a very mild symptoms, and stage 3 being the latest or the severe inflammation, the question is, where do we introduce steroid? If we introduce steroid at stage 1, we know that corticosteroids are going to increase the viral shedding. So if we start at stage 1, we could possibly increase the viral application. However, and then the other argument is, if we start steroid at stage 2, then stage 3, then there's already hyperinflammation. So therefore, is there really a benefit to starting steroid at that stage? So when considering starting steroid therapy, it needs to be a balance between that window, whether because we know starting too early and starting too late, it's going to have detrimental effect. And because of that, there has not been a really concise guidance from the recommending body. So most of the guidance recommend against using corticosteroids. So the IDSA, NIH, the Surviving Sepsis, as well as the WHO, they recommend against using corticosteroid for the management of COVID-19. However, the Surviving Sepsis does endorse the use of corticosteroid in patients with COVID-19 who concomitantly have ARDS as well as septic shock. And it's kind of the same thing with the NIH and the WHO, in that they say that if a patient does have a COVID-19 concomitantly with a septic shock, then the steroid therapy can be beneficial in those patient population. And I just wanted to review a few studies that looked at the steroid therapy in COVID-19 patients. So the first study came out of Wuhan. This is conducted by Lu and colleague, and here they looked at 109 patients, and they sort of stratified patients into COVID-19 non-ARDS patients as well as COVID-19 ARDS patients. And what they found was that although they did not specify the type of steroid that they use, there was no significant difference in the survival of COVID patients with ARDS in these patient populations. The next study was, again, it came out of Wuhan, and they looked at the use of methylprednisolone at a dosage of 1 to 2 milligram per kilogram for 5 to 7 days. And what they found out was patients who actually received the methylprednisolone had a faster improvement in SpO2 by about 6 days. So patients who received the methylprednisolone had significantly long. Patient who did not receive the methylprednisolone had a significantly longer interval of using supplemental oxygen compared to those that received the methylprednisolone, again, by about 6-7 days. The last study was from Michigan. So this is a multi-center quasi-experiment that looked at a pre-corticosteroid treatment and a post-corticosteroid treatment. Here again, they used a methylprednisolone, but here the dose was a bit more conservative. So they opted to use the 0.5 to 1 milligram dose. And here what they found out was there's a reduced escalation of care and improved clinical outcomes in those patient population that have seen that were given those corticosteroid. One of the things that I want to highlight within all these studies is that there's a whole bunch of limitation, right? One, we see that there's a variation between the different studies that were conducted. Number two, it's important to note that these are not peer reviewed, and the patient population are very homogeneous. And if you look at the sample size, it's a very, very small sample size. So although there's some conflicting results, also there's a lot of limitation within these studies. So I just want to highlight the recent press release from the UK with the recovery trial, and kind of highlight and talk about some of the results that were found within the study. So this is one of the largest studies that's being conducted currently. The recovery trial is an open label randomized clinical trial across 175 centers in the UK. And it's looking at patients with suspected or confirmed SARS-CoV-2. And that had a very complex randomization. So patients can be randomized to receive any 5 available treatments. So patient can be in the no treatment group, patient can be in the lopinavir, ritonavir, a corticosteroid, or a corticosteroid hydroxychloroquine as well as the azithromycin, and patients were randomized 2-to-1 from the no treatment to the treatment group. Now, like I said, this is one of the most complex randomization in that one, the providers can opt to choose which arms that the patient wants to get, which medications that the patients can get. So the randomization was very, very complex. But they looked at the mortality rate of 28-day mortality. And what they found was that in patients who received the dexamethasone, the overall mortality rate was decreased by about 17%. Specifically, those that were receiving the oxygen requirement had a highest mortality benefit, and when it comes to the corticosteroid therapy. Again, for those that are receiving mechanical ventilation, the mortality benefit dropped to by about one third or so. But the mortality benefit was seen in patients with severe presentation and in those who require mechanical ventilation and oxygen requirement. Interestingly enough, in patients who were not requiring any oxygen therapy, they did not find any benefit, or they did not find any significant reduction in mortality. So, with that being said, I think having some sort of optimism in COVID-19, it's always positive. I think we need something positive in the midst of everything that's going on, but the optimism needs to be cautious, right? The results from the recovery trial are very promising, but there's still a lot of variables that are not yet answered. Because of the study is not published, because we're getting some of the results from the press release, we're not able to really take a real full deep dive and assess the study in full. So the timing of steroid therapy is not really discussed. The other intervention and crossovers that were that could have been are not discussed, and the variation in patient population is also not discussed. We know that in the UK they sort of have a higher mortality rate compared to other maybe here in the United States and maybe back home in Ethiopia. So there's a lot of limitation, and there's a lot of things that need to be that needs to come out before we start giving dexamethasone to everyone. A few studies and guidelines have also adopted the use of corticosteroid in patients with moderate or severe COVID-19 patients. But however, the last thing that I want to mention within the corticosteroid realm is that the timing of corticosteroid is crucial. Too soon, we increase the viral shedding. Too late, it's going to have no benefit. So lastly, in the next couple of minutes, what I want to do is I want to talk about the role of pharmacists. So we know pharmacists play a huge role in the management of COVID. And number one, I think we can make medication simplification in the sense that we want to reduce the nursing exposure. So switching maybe shorter acting to longer acting agents, simplifying regimens, maybe if we can dose a drug once a day as opposed to twice a day or 3 times a day, it sort of limits the exposure and reduce the amount of PPEs that we use. Hyperglycemia management is a key role that pharmacists also play a role. There have been a few reports that COVID-19 actually suppresses the beta pancreatic islets, which leads to refractory hypoglycemia. So by making sure that their glycemic is under control, by under control I'm meaning that within the goals for ICU care, pharmacists play actually a big role in that. And lastly, fluid management, whether it be a patient requiring TPN or a patient requiring a large amount of pressors, pharmacists can play a role in concentrating those infusions, and again, really limiting those the nursing exposures, as well as saving those PPEs by not going into the rooms, or by not going into the rooms quite often as much. So that concludes my presentation, and I'm happy to take any questions now.
So our first question was, what are I know you mentioned a couple of them, but the question was, what are the pharmacological agents that we can use in these patients for anticoagulation? Is it warfarin, heparin, or new anticoagulants such as DOACs?
The recommendation from the various guidelines and what I've seen in clinical practice is to use those low molecular weight heparins or unfractionated heparins. I haven't seen much of warfarin that is being used for prophylactic. However, again, for patients who could possibly get discharged, or for patients who are hospitalized and getting discharged, then the recommendation is that we can if a patient cannot tolerate heparin for some reason or the Lovenox for some reason, then we can introduce those new oral anticoagulants, but not warfarin.
Second question was, why was the recovery trial prematurely terminated?
So it has a bunch of arms. I don't know if it's prematurely terminated. I'm not aware of it being terminated. I know that I believe the hydroxychloroquine arm, I believe, did get terminated early, but don't call me on that. But we don't know until they release the full data and the full results to really dive into it. But I'm not sure if it's fully terminated. I could be wrong.
And our last question for this section is, what is the percentage of steroid familiarity in stage 3? I think this is maybe referring to one of your studies. Not sure, Murteza Mohammed, if you can clarify that question.
So I think the question is, the death doesn't really come from the corticosteroid therapy. I think death comes obviously from the complication of the COVID-19 presentation. I think that depiction in terms of the stage 1, stage 2, and 3 was just to sort of highlight the progression of the disease states and to emphasize that if we start a corticosteroid therapy a little bit too late, then there might not be any benefit in those patient population.
Okay. Hopefully I answered your question, Murteza. And one more question. Do pharmacists directly are involved in ICU in the USA? Definitely. I myself and my colleagues are involved in the ICU care setting with COVID patients, from bedside rounding to interdisciplinary team for this patient population. So yes, it's very common that pharmacists are directly involved in the ICU setting over here in the United States. Couple more questions, but
I have one question I just wanted to ask.
Go ahead.
Dr. Katema. So I know you talked about it, the balance of therapeutically anticoagulating patients and not. Do you find that in your practice that you are more so leaning toward therapeutically anticoagulating patients, like reaching the therapeutic targets instead of prophylactically managing patients?
Yeah.
And then if so, like, did you do therapeutic drug monitoring with prophylactic regimens?
Yeah, I think historically, right when COVID, just to give you a little bit more context, when COVID initially appeared here at our institution, and when patients would go onto CRRT, patients would actually clot, and we were having to use TPA to break those clots because heparin were not really doing anything from that perspective. So, but at the same time, we were not starting heparin in the prophylactic dose early on, right when they presented. So at least at our institution, the recommendation or the practice is to start everybody who's hospitalized on the prophylactic dose of heparin. Now, if the patient does have an indication to get the therapeutic dose, then it sort of makes everything easier. So that'll be the indication to start a full therapeutic dose. But however, today, the practice is that we do the prophylactic dose unless there's some more abnormalities or there's presence of clots or things like that that would warrant the full therapeutic dose. In terms of the intermediate dose, that 0.5 mg per kg, we don't do that in practice, but I've seen it in a number of institutions that they actually do those immediate intensity anticoagulants.
Yeah, same. I've seen the same. And then even when you do prophylactic regimens, because they want to know, how they want this like kind of not really, supported literature, but instead of targeting the therapeutic, 0.5 to 1, if you're on like enoxaparin or something, then you target 0.3 to 0.5 or something like that. I've seen that too.
Yeah.
I just don't know if it was, institution based or not, which probably is, but yeah, I thought I'd ask. So thank you.
Yeah.
Thank you. So we got to move on. For those who are asking questions, Behalu, Mulino, we're going to have an email at the end of the presentation where you can forward those questions to that email, and then we're going to answer your questions via email. But without further ado, our next segment, our last segment, will be presented by Dr. Mikia Stafari. If you would like to share your screen for us, please, and go ahead and start whenever you're ready.
Thank you very much. So I'm going to briefly go through the management of Ethiopia. So to start with, currently there is a section in which is a case management section at the Emergency Operations Center under the Ethiopian Public Health Institute, which is responsible for developing this case management guidelines and the different protocols and following and adhering to adherence of these treatment centers and isolation centers and also the quarantine centers to the developed protocols. So I'm the unit lead for this clinical management unit. So when we see the management for COVID-19 in our setup, it is since it is we have a clinical advisory team composed of senior specialists from different office to develop this clinical management guidelines. So it has been developed since the beginning of this response. So currently it is updated. It is being updated for the third time. So when we see it is regarding the case management, so clinical syndrome. So there's patients with mild illness, moderate illness, severe illness, and those with critical illness. So I will go each management. So regarding the mild illness and those with individuals, at the beginning we used to admit all this asymptomatic COVID positive. No, the number is not as such. So we used to admit this individuals to our treatment centers and follow their vital signs, and we will see if they have any progress for we are currently doing regarding the management of this mild illness. So is the same. Just we're following for any deterioration in vital signs, deterioration in any clinical symptoms. So the second group of patients will be those with moderate illness. So these patients are admitted to the hospitals, and we are going to follow them closely for any deterioration, and also they will be on oxygen to maintain their saturation within 92%, and if any need will be there, we're going to administer the IV fluids and other supportive treatment. This will be there for this moderate illness, and also severe illness will be on oxygen therapy and also other supportive treatments. And the different thing here will be they will be put on broad spectrum antimicrobial empirically after taking specimen for culture and on sensitivity. So they will be put on empirical antimicrobials, and the critical ones we will admit them into the intensive care units, and the details of this management regarding to their supportive treatments and the need is there. So to add some pointers, what we have progressed through this clinical management, we have as I mentioned earlier, currently the clinical management guide is a big document. I didn't go in detail just for the sake of time. So previously we used to recommend those anti-malarial drugs, but currently we have omitted them from the case management, and also current management regarding this critical patients. So apart from those supportive treatments with those with ARDS and antiretroviral and also immunomodulator management, like convalescent plasma transfusion and the use of steroids, and also antiviral treatments are also included in our management. So with its own recommendations, so patients will also get the anticoagulants for COVID-19 patients. So I didn't go through the details of this clinical management. As I mentioned earlier, there is a team, a clinical advisory team for the Ministry of Health, and also the COVID-19 case management team at the they are the ones who developed the hospitals using this clinical case management guideline. So presentation about the case management in our country. Hello.
Yes.
Paulus?
Yeah, I'm here. Sorry, Kapka. I was just monitoring the chat for it. Any questions? I think ሁለት ጥያቄዎች አሉ. I think we can sort of take at it. The first question is, Ethiopian Ministry of Health have declared that they'll use dexamethasone for treating COVID-19. The question is, should they use it for all oxygen requiring individuals, including those who are not on mechanical ventilations? I think I can say something, and in Dr. Mikias, you can see how the practice is there. I think it's important to not just give dexamethasone for all patients. I think there is some patient population that could possibly benefit and with the use of steroid. I think the severe patients may actually benefit from it, but I think it may not be, at least until the paper fully comes out. I would say that it may not be feasible to give all patients who are receiving oxygen therapy dexamethasone. And Dr. Mikias, you can maybe highlight.
So currently in our case management guide, it is recommended to use dexamethasone for those critical patients.
Okay. The next question is, per the UK study, dexamethasone did not benefit patients who did not need oxygen support. Does this mean dexamethasone is suppressing some specific immune response in severely ill patients, which actually made them susceptible? And suppressing some specific. In terms of the exact mechanistic, I don't know if it's very well understood. It could be the immunosuppressive effect of it by decreasing some of the pro-inflammatory biomarkers. But as to the exact mechanism of how it actually benefits COVID-19 patients, it's still yet to be determined. The next question, Dr. Mikias, is, what is the approximate ratio of mild, moderate, severe cases, and what is the prognosis?
So as you see the daily updates from our minister, we do have a good prognosis, and also the percentage of those asymptomatic patients is very high in our country, and those with severe cases are very few in number. And as you see, the number of cases from our admitted cases is very few in number when we compare it to those with the positive cases, the total number of positive cases we have. So it's less than 5% of the patients are having severe and critical symptoms. So those asymptomatic and mild cases are more than 90% of the total COVID positive confirmed cases.
If I can just follow up with a question, when do you expect to see the peak of the COVID-19 infection? Have we already reached the peak, or have we already gone past it? Where do you expect to see any peak in the upcoming weeks or months?
So still, we didn't pass a peak. So as you see, the number of cases daily being positive is higher than those being discharged from our treatment centers, being recovered. So still, we're not at the peak. I think we're expecting it the coming days, in the coming weeks.
Okay. Any other questions from the chat? So I'm not seeing any other questions, Dr. Yes. So we'll sort of conclude today's presentations, but before we do so, I just want to give a brief thank you to all the speakers, Dr. Mikias, Dr. Iman Ahmed, Dr. Rania, as well as Dr. W. Hussein. Thank you so much for putting this together. We do have a few upcoming webinars. July 3rd webinar, that will be webinar number 9. It'll primarily focus on traditional medicine and supplements and regulatory matters in Ethiopia. Webinar number 10 and 11, which will take place on July 10th and July 17th, will focus on the opioid epidemic and its with the COVID-19. There's an asterisk behind webinar number 10 and behind 10 and 11, because those webinars will be associated with a CE. So for all pharmacists who are required, who need CE, this will be the great opportunity to attend a great webinar, as well as get some of the CEs that may be a requirement. So I just want to again thank you so much for everything, and this concludes today's presentation. Thank you, everyone.
Thank you.